Okay, so good morning to everyone, and welcome again to the UCT-Africa virtual ENT training platform. My name is Matthew White, and I'm one of the registrars here at the University of Cape Town. And this morning, I'm going to be talking around laryngopharyngeal reflux disease, which going forward I'll refer to as LPR. Just a few of the usual house rules before we get started. If everyone could please keep their microphones muted for the duration of the talk. Should you have any questions during the talk, you can either use the chat function or the raise hand function. So without further ado, I'll get started. So just the usual brief disclaimer: I've written consent from the patients to obtain and share their clinical details on this platform, and all my content is referenced. So in terms of definitions, to introduce LPR as an entity, we must define it. An older definition by the American Academy defines it as the retrograde movement of gastric content, including acid, bile, and digestive enzymes, into the laryngopharynx, leading to symptoms referable to the larynx or hypopharynx. Just as a side note, in a more recent review published this year in Head and Neck, the authors revised this definition to an inflammatory condition of the upper aerodigestive tract tissues related to the direct and indirect effects of gastroduodenal content reflux, which may induce both morphological changes in the upper aerodigestive tract as well as kind of almost a neural hypersensitivity. The authors made this change to take into account the fact that LPR does not only affect the laryngopharynx, but also it's now recognized to affect the entire upper aerodigestive tract mucosa, and that LPR is mediated by both direct mucosal inflammation caused by reflux, but also secondary to a more complex indirect vagally mediated neural hypersensitivity. Common synonyms used in medical literature include extraesophageal reflux, reflux laryngitis, supraesophageal reflux, gastroesophageal reflux, and pharyngoesophageal reflux. Also, just to emphasize that LPR is a separate entity to gastroesophageal reflux disease, and it may occur in isolation or in conjunction with gastroesophageal reflux disease. Gastroesophageal reflux specifically refers to the physiological reflux of gastric contents beyond the lower esophageal sphincter and into the esophagus, which may or may not be symptomatic. Gastroesophageal reflux disease is essentially symptomatic gastroesophageal reflux, which can further be subdivided into erosive reflux disease, which describes a spectrum of mucosal ulceration and inflammation seen on esophagoscopy; non-erosive reflux disease, which are patients with symptomatic gastroesophageal reflux, but with no mucosal changes on esophagoscopy. And then Barrett's esophagitis is a pre-malignant complication of GERD, in which, due to recurrent refluxate, the stratified squamous epithelium of the esophagus undergoes focal areas of metaplasia into dysplastic columnar epithelium, which can undergo malignant transformation into adenocarcinoma. If we look at the epidemiology, due to the difficulty of defining LPR, the overlap of symptom complexes and the lack of a universally accepted diagnostic modality, the true incidence of LPR is in fact yet to be clearly defined. Using a non-specific reflux symptom scores, the incidence of LPR in the general population is thought to be between 10 to 18%. Studies using dual probe pH monitoring show an incidence between 4 to 10% in general ENT clinics. And similarly, in a study of 113 patients presenting with dysphonia to a voice clinic, 69% of patients had clinical features in keeping with LPR, and 73% had abnormal pH testing. The US annual cost for treating LPR and GERD is estimated at between 9.3 to 50 billion US dollars, with one study in the US revealing that the mean cost to a patient in the first year of assessing, investigating, and treating LPR was a whopping 5,438 US dollars. What is further predicted is that the incidence and prevalence of LPR will inevitably increase in Western society with an increase in obesity, acidification of foods, the increased consumption of fast foods, and an overall increased rate of a sedentary lifestyle. Possibly driven by the clear burden of disease and potential for money to be made, there's been a massive increase in clinical studies in the field of LPR, which is illustrated in this graph taken from a 2018 review article, which illustrates the evolution in the number of publications on the subject over the last 6 decades. Despite the high prevalence and the abundance in the medical literature and increasing knowledge of LPR, both in the general medical and ENT fraternities, the actual knowledge of the condition is relatively poor. In a European study conducted by Lesions et al. In 2019, assessing the awareness of LPR amongst 230 ENTs and 70 GPs, the following responses were found. Amongst the GPs, 10% considered themselves adequately knowledgeable and skilled about LPR, and 70% believed they were not. I know certainly I never had heard of LPR until I started my ENT training. Similarly, amongst the ENTs, 54% considered themselves inadequately knowledgeable and skilled about LPR. 27% believed they were, and 19% were on the fence. And hopefully, by the end of the talk today, you'll feel more enlightened than the participants in this study. From a pathophysiological point of view, the reflux of gastric contents into the laryngopharynx and esophagus is prevented essentially by 4 physiological mechanisms. Firstly, the lower esophageal sphincter, which is formed by the circular muscle layer at the distal esophagus together with the crural muscles of the diaphragm at the OG junction. This lower esophageal sphincter relaxes during the phase of swallowing, and at baseline is tonically contracted to prevent reflux in between swallowing. The upper esophageal sphincter is formed by the cricopharyngeus, thyropharyngeus, inferior constrictor, and proximal esophageal muscles. And as we know, is innervated by branches of the vagus nerve and to a lesser extent, the glossopharyngeal nerve and sympathetic nerves. The esophageal motor function and peristalsis also is protective in that it promotes prograde flow of ingested products. And lastly, the mucosal resistance inferred by the stratified squamous epithelium of the esophagus is protected, but importantly, the larynx, which is instead lined by a predominantly less resistant ciliated pseudostratified columnar epithelium predominantly, has a lesser defense. Gastric reflux itself ranges from frank liquid to finer drop or gaseous forms. Historically, the hydrochloric acid of the refluxate was considered to be responsible for the disease. However, we now know that in fact the principal offender or catalyst are proteolytic gastric enzymes, specifically pepsin, as well as to a lesser extent food residues, bile acids, and bacteria. And as a result of this recent discovery, the terms acid, mixed, and non-acid refluxate have been coined. More specifically, pepsin is a proteolytic enzyme that's thought to play the primary role in pathogenesis of Lpr. It's produced in its inactive form by the chief cells in the gastric mucosa as trypsin or pepsinogen, which is activated by hydrochloric acid or other acids at a pH of less than 6. and is deactivated at a pH over 8. In its active form, the proteolytic enzyme causes laryngeal or esophageal inflammation. It's also able to bind to the mucosa and is even taken up by some of the epithelial cells, where it can subsequently be reactivated by ingestion of acidic foods or the refluxate of acidic gastric contents. Hydrochloric acid, which was once thought to play a major role through its caustic action in kind of inducing tissue inflammation, is now thought to induce more of its tissue injury indirectly through the activation of the pepsin. The role of Helicobacter pylori in Lpr is still yet to be determined. We know it plays a significant role in peptic ulcer disease, gastritis, and possibly esophagitis. In a 2017 systematic review and meta-analysis, H. pylori was found in 44% of patients with Lpr. However, there was no significant evidence to support the use of routine eradication in the treatment of Lpr. As I mentioned earlier, an indirect, vaguely mediated neural hyperresponsiveness is now well described in the pathogenesis of Lpr. The direct mechanism refers to the direct caustic mucosal irritation caused by the refluxate, and the indirect mechanism refers to a secondary, vaguely mediated neuropathic hypersensitivity, which then manifests in chronic cough, throat clearing, which is thought to cause a subsequent phonotrauma with further mucosal injury and exacerbates the symptomatology further in an almost self-perpetuating type cycle. A rarer secondary cause of Lpr, which I actually have amazingly seen once in our clinic, is the entity of a heterotropic gastric mucosal patch, which is thought to be a congenital condition in which ectopic gastric mucosa occurs in the proximal esophagus, as illustrated in the image. The diagnosis is obviously confirmed on biopsy. So what is the difference between Lpr and gastroesophageal reflux disease? Firstly, it's important to make the distinction that there are two separate entities, which, as I mentioned earlier, may occur in isolation or conjunction. Unfortunately, there's significant symptom overlap and a common underlying pathophysiology, often making it difficult to distinguish between the two. Common symptomatology attributed to gastroesophageal reflux disease includes heartburn, typical kind of postprandial retrosternal discomfort, bitter regurgitation into the oropharynx, dysphagia, water brash or hypersalivation, globus sensation, odynophagia or nausea, just to note symptoms of which are also experienced in Lpr. And at present, it's believed that a large proportion of patients with Lpr do not actually have associated gastroesophageal reflux disease. And a common symptom I've witnessed being used for screening in the clinics for Lpr is the presence or absence of heartburn. However, it's actually been found that only 40% of patients have reported heartburn of Lpr patients. And similarly, 25% have associated features of esophagitis on endoscopy. The above tabulated differences have been postulated between Lpr and gastroesophageal reflux disease in the literature. Lpr is thought to be primarily a deficiency at the level of the upper esophageal sphincter, whilst gastroesophageal reflux disease is the deficit is primarily at the lower esophageal sphincter. Lpr patients are thought to experience briefer episodes of reflux, as few as 4 times a day in the upright position may become symptomatic, whilst in gastroesophageal reflux, multiple prolonged acid exposures occur typically, usually at night in the supine position. The laryngopharynx, as I mentioned earlier, is thought to be more susceptible to caustic injury due to the lack of its peristaltic clearance and a thinner mucosal epithelial surface compared to the esophagus. Lpr is associated also with a lower incidence of associated esophageal dysmotility when compared to gastroesophageal reflux disease. Moving on to the symptomatology of Lpr, multiple symptoms are reported, and in a 2019 systematic review and meta-analysis of 69 studies, the top 10 symptoms are highlighted in the red and reported in order of incidence are voice disorders or varying degrees of dysphonia, I suppose, throat clearing, a troublesome cough, globus sensation, dysphagia, stomach acid coming up, excess throat mucus, postnasal drip, postprandial coughing or coughing after lying down, with less than 10% experiencing a dinophagia, a burning tongue, a tolgia, or wheezing. And one wonders, in fact, whether these were not patients with other comorbidities or incorrect diagnoses in which these symptoms were reported in. And just to emphasize that I feel one must be careful in attributing referred tolgia to Lpr and not a more sinister, possibly malignant underlying condition. The reflux symptom index is one of multiple standardized scoring systems which has been designed to assist with the diagnosis of Lpr and assess response to treatment. It's not used much outside of research, but essentially it looks at the severity of 9 reflux-related symptoms, each scored out of a maximum of 5, where a score of 13 or more is suggestive of Lpr. And an improvement in score by more than 5 is thought to indicate a good response to treatment. It has a good overall sensitivity for Lpr, but like many things in Lpr, lacks specificity. Therefore, it's important to be aware of other causes of laryngeal inflammation, which may also increase your RSI, such as smoking, alcohol consumption, allergy, viral and bacterial laryngitis, as well as vocal abuse. The lack of sensitivity was illustrated recently in a 2020 retrospective cohort study in which the RSI was done in all patients presenting to a tertiary voice center. And as you can see, multiple other diagnoses scored over 13 on the RSI, and also interestingly had an associated reduction in RSI following treatment. The clinical approach to a patient with suspected Lpr obviously includes a full ENT and systemic examination, where it's important to be aware of the previously mentioned other causes of laryngeal inflammation, but also not to miss important red flags which may point towards a more sinister underlying condition. One should exercise extra caution in diagnosing Lpr in patients with risk factors for head and neck squamous cell carcinoma or other malignancies, specifically smokers and patients with strong history of alcohol consumption. And the red box clinical features and signs and symptoms are features specifically not of Lpr and should raise the suspicion of more sinister, possibly malignant underlying pathologies. These include a loss of weight, disproportionate or excessive pain, lymphadenopathy or associated neck masses, cranial nerve palsies, aspiration symptoms, referred atolgia, as I mentioned earlier, stridor, reduced vocal cord mobility on laryngoscopy, and a poor response or a progression despite adequate treatment. Moving on to findings on endoscopy and stroboscopy, they are universally associated with a high sensitivity but low specificity, and again are much like the symptoms not unique to Lpr. And it's documented that endoscopic abnormalities may be present in up to 70% of healthy asymptomatic patients. Similarly, they may only be present in as few as 50% of patients with symptomatic Lpr. And there's no single sign which is pathognomonic of Lpr. And if we return to the same 2019 meta-analysis, we see up to 30 different endoscopic findings reported in the literature. The 10 most commonly reported endoscopic findings are highlighted in the red and include laryngeal and arytenoid erythema, granuloma or granulation, interarytenoid nodularity, generalized laryngeal edema, posterior commissure hypertrophy, vocal fold edema, thick endolaryngeal mucus, subglottic edema or pseudosulcus or even stenosis, ventricular obliteration, vocal fold erythema, and laryngeal ulcerations. And with the yellow highlighting the features occurring less commonly in 5 to 10% of patients. Again, like the symptoms, the features may be found in other causes of laryngopharyngeal inflammation. The reflux finding score was introduced in 2001 and is an endoscopic scoring system created to assist with the standardization of diagnosis of Lpr. It again has limited use outside of research. Essentially, they look at 8 endoscopic features and score them as indicated on the right, where a score of more than 7 is thought to be indicative of Lpr. Overall, it is again associated with a high sensitivity of up to 80%, but a poor overall specificity of between 40 and 50%. And it's unfortunately subject to inter-observer variability. This series of images illustrates some of the more commonly described features associated with Lpr. In image A, there's redness of the oropharyngeal pillars. B, the so-called coated tongue, again with erythema of the oropharyngeal pillars. In C, we see nodular inflammation of the posterior oropharyngeal wall. In D, we see vocal cord ulceration. In E, we see lingual tonsillar hypertrophy, sticky saliva, and nodularity of the posterior pharyngeal wall. In F, posterior laryngeal hypertrophy and sticky saliva in the piriform sinuses. In G, again, sticky endolaryngeal mucus. H, keratosis of the vocal processes and left arytenoid, and edema of the free edge of the left vocal cord. And just to again mention that obviously keratotic lesions or unilateral vocal cord edema must not easily be written off to Lpr and may actually require a full pan endoscopy to exclude either laryngeal dysplasia or early squamous cell carcinoma, or in the case of unilateral vocal cord edema, a tumor in the ipsilateral laryngeal ventricle. A Pseudosulcus Vocalist is postulated to be one of the more specific findings of Lpr, with one study showing a positive predictive value of 67 to 90% for Pseudosulcus in the presence of Lpr symptoms. The Pseudosulcus describes a pattern of edema on the ventral surface of the vocal cord. It extends the entire length from the anterior commissure to the posterior commissure. And is also present in that same image A is posterior commissure hypertrophy and glottic edema. This is a different entity to a true sulcus vocalis, which refers to a groove or invagination of mucosa along the surface of the vocal fold or true cord. In the area of the sulcus, the mucosa is scarred down to the underlying vocal ligament, giving it an almost retracted appearance, and is typically described over the midpoint striking zone of the vocal ligament and stops at the vocal process of the arytenoid. Causes of true sulcus vocalis include congenital causes as well as phonotrauma, and we know that it's been subclassified by Ford and colleagues into 3 subtypes. A newer reported finding in Lpr is a mucosal line at the level of the inferior aspect of the nasopharynx, which is thought to be relatively specific for Lpr. So the role of Lpr in benign vocal cord lesions is another point of controversy and ongoing investigation. The potential role of reflux in each benign vocal cord lesion is beyond the kind of time constraints of this presentation, But the above systematic review is a good summary, which includes 155 publications. And essentially the conclusion was that there may be an association between LPR and vocal cord nodules, polyps, and Renker's edema, where it's thought that the caustic mucosal injury from LPR causes an increased susceptibility of the vocal fold mucosa to phonotrauma and the subsequent development of benign vocal cord lesions. It was also shown that there's no strong evidence to support an association between LPR and vocal cord cysts and the previously mentioned Sulcus vocalis. So moving on to the investigations, LPRs, I hope it's going to become clear, is not as easy as one thinks to diagnose. However, it's still important to emphasize that it's kind of predominantly a clinical diagnosis where further investigation is reserved for cases of diagnostic doubt or treatment failure. And I think it's fair, and the literature actually supports this practice, that in a patient who has features suggestive of LPR without another cause to better explain their symptoms, and an absence of the red flags, the use of an empiric trial of response to PPIs as a diagnostic modality is fair. Here, symptomatic improvements or reflux severity indexes can be used to assess response of treatment. These are usually given over a 3-month trial period. The obvious problem with this approach is that it cannot distinguish between recalcitrant LPR and a truly incorrect diagnosis. But it is a useful approach to avoid over-investigation of patients, particularly in resource-constrained environments. Contrast fluoroscopy has no findings truly specific of LPR and is rather used as an adjunct if other diagnoses are suspected, such as Zenker's diverticulum, strictures, tumors, or a hiatus hernia, which may either be contributing to the patient's reflux or in fact mimicking it. Esophageal and extraesophageal reflux may occur or may be witnessed at the time of fluoroscopy. However, usually it's not. And again, where it is, it may be an incidental finding in healthy individuals. As I mentioned earlier, many healthy asymptomatic individuals may have normal physiological reflux. Earlier studies described the findings illustrated in the above kind of contrasted swallow and were thought to be suggestive of extraesophageal reflux and may be associated with LPR. So essentially in image A, it shows a retained liquid barium fluid above the aortic notch on the post-esophageal phase of a barium swallow, following which the patients are actually instructed to take a dry swallow, during which the upper esophageal sphincter relaxes and the barium is seen to escape or reflux proximately as a thin kind of fluid volume seen in images B and C. And finally, we see that the barium then penetrates over the arytenoids to enter the laryngeal vestibule with penetration, but no associated aspiration. Newer tests are being developed to assess for the presence of digestive enzymes like pepsin and triacetyl bile salts, where either saliva or tissue biopsies are tested. Tests specifically for pepsin are showing the most promise, and it's logical as LPR is now thought to be largely pepsin mediated. Here, biopsy specimens can be stained for the presence of pepsin, but this is obviously invasive and hard to justify as it's not used and therefore is not used much outside of research purposes. In the UK, a test is now available, and I think actually more universally available by now, is for the presence of pepsin in pharyngeal secretions under the kind of trade name Pep Test. The test is allegedly entirely non-invasive and is easy and relatively cheap to perform. In the test, the patient expectorates kind of pharyngeal secretions into a specimen tube containing a reagent, and a positive or negative result is obtained after about 15 minutes. The overall sensitivity of the Pep test ranges from 43 to 80%, whereas the specificity ranges from 55 to 78%. In 2017, systematic review by the American Academy looking at the utility of pepsin testing, they found that 10 out of 12 studies revealed statistically significant differences for pepsin and Lpr compared with healthy case controls. They found that the biopsy technique was unsurprisingly more sensitive, but could not conclude which was the best area to in fact biopsy. Sites biopsied included the post-cricoid area, interarytenoid mucosa, vocal fold, ventricle, posterior commissure, and hypopharynx. And basically, to sum up this review about pepsin, it basically suggests that it might be a reliable marker in patients with Lpr, although there are kind of many questions that remain about the optimal timing, again, the location, nature, and threshold values for pepsin testing. Esophageal manometry has little value in the diagnosis of Lpr. Its main role is in the diagnosis of motility disorders which may mimic or contribute to Lpr, where essentially a manometer consists of the tube which is passed nasogastrically into the esophagus, which records pressure changes in the esophagus. We then receive data on the contractility, resting tone, and coordination of the esophageal sphincters, as well as the peristaltic wave. Certain patterns are pathognomonic of conditions like achalasia or hypermotility or spasmodic disorders. 24-hour multi-channel intraluminal pH monitoring is perhaps considered now the gold standard for diagnosis. It combines proximal and distal pH monitors to detect acid reflux with also with multiple electrodes which measure electrical resistance, as which record the so-called non-acid reflux episodes. It's now replaced dual channel pH monitoring, which was kind of previously declared the gold standard in 2002 by the American Academy. In this test, the probe is placed nasogastrically using manometry or endoscopy to locate or estimate the upper and lower esophageal sphincters. The probe is secured to the nose and connected to a receiver, which is worn around the waist for 24 hours. And you then receive real-time monitoring at the level of each electrode and pH monitor. While wearing the unit, patients are encouraged to continue with routine daily activities and diet. PPIs have to be stopped 7 days prior, H2 receptor antagonists 2 days prior, and acids must be stopped 6 hours prior. More than 4 episodes of acid reflux over a 24-hour period is thought to be consistent with the diagnosis of Lpr. Limitations of this test include that it's obviously invasive, it's expensive and time-consuming, and it may in fact be positive in 16 to 21% of asymptomatic individuals. It's important to note that the number of episodes does not determine the severity. And there's further no consensus at the moment regarding the defining pH level of a reflux episode. Traditionally, based on gastroesophageal reflux studies, a pH of less than 4.5 was used, but this is being challenged as we now aware that pepsin is activated at pH levels of up to 7. Newer techniques are also being investigated, which include airway pH monitoring with a less invasive oropharyngeal probe. So moving on to the management of Lpr, the literature is universally in support of dietary and lifestyle modification, and it should be implemented as first line with or without a PPI. These measures aim to reduce the number of reflux episodes and the acidity of oral intake and refluxate. The normal pH of food is actually between 2.5 to 6. where LPR diets aim to promote low acid foods, which are typically kind of a Mediterranean style diet, typically with a pH of over 4, and include products such as meat, poultry, seafood, some dairy, and vegetables. And one should aim to reduce low pH foods, which unfortunately includes most fruits, fruit juices, especially citrus and tomatoes, jams, jellies, and spicy foods. And there's no evidence to support alkalinization of water or any food products. Beverages which cause esophageal sphincter dysfunction and weakening should be eliminated and include caffeine or carbonated drinks, alcohol, chocolates, and peppermints. Smoking should obviously be stopped as it stimulates acid production and promotes reflux. And other measures in the literature include eating more frequent, smaller meals throughout the day, as opposed to the traditional 3 large meals per day. Weight loss to reduce gastric pressure. One should avoid eating or drinking 2 to 3 hours prior to exercise and going to sleep, as well as one can attempt to elevate the head of the bed at night. In terms of the pharmacological management of Lpr, there are 4 classes of agents described: proton pump inhibitors, H2 receptor blockers, antacids, and neuromodulating agents, where PPIs essentially work by reducing gastric acid production by blocking the hydrogen and potassium proton pump of gastric parietal cells. Of the pharmacological agents, they are actually the most potent suppressors of gastric acid production. And in Lpr, they're thought to work by decreasing the acidity of the gastric refluxate and therefore decreasing the caustic injury and activation of pepsin. Importantly, they must be taken on an empty stomach 30 minutes prior to meals. This is because the systemic absorption is delayed by food. Benefits include obviously that they're cheap and have a relatively low side effect profile. Some of the adverse effects described include GIT upset, nausea, vomiting, hypomagnesemia, phosphatemia, calcium, and vitamin B12 deficiency, and therefore an increased risk of osteoporosis. Increased susceptibility of Clostridium difficile infection, as well as an increased risk of pneumonia. I think this is more in critically ill or ventilated patients. Historically, there was also a concern that prolonged use of PPIs may be in fact associated with an increased risk of gastric cancer. However, in a 2014 Cochrane review, they reached the conclusion that PPIs may be associated with benign gastric polyps, but there's no clear evidence for an association with malignancy. However, the use of PPIs may mask the symptomatology of a gastric carcinoma. So what is the evidence to support the use of PPIs in Lprs? In Lpr, well, there isn't any strong evidence really. Amazingly, in 2006, Laryngoscope published a systematic review of 21 studies and came to the conclusion that, and recommendations that the use of PPIs in Lpr is based on poor levels of evidence, and that few randomized control trials failed to demonstrate any benefit over placebo. This was again revisited more recently in 2019 with a systematic review and meta-analysis of 72 studies, which revealed only a mild superiority of PPIs over placebo and emphasized the importance again of dietary measures. So there seems to be no strong evidence in support of PPIs really. So again, there's a clear lack of consensus in the literature regarding PPIs. And despite the previous 2 studies I mentioned, both Scott Brown, the American Academy, and Cummings advocate for the use of PPIs with dietary measures in the first line of treatment of Lpr. There's no consensus again regarding the optimal dosing. Some advocate upfront twice daily dosing. Others advocate initial once daily dosing with an increase to BD dosing if there's no response. But twice daily dosing, I must say, seems logical if you look at the duration of action of the majority of PPIs, with the maximal acid suppression being inferred for up to 14 hours. In terms of the duration of treatment, most guidelines recommend a minimum trial of 3 to 6 months, where responders are continued for a total of 6 months, following which treatment should be tapered off over a period of 6 to 8 weeks. And it's important to mention that treatment should not be stopped abruptly, as patients can experience a rebound acid reflux phenomenon. The second group of agents is the H2 receptor antagonists, agents like cimetidine or ranitidine. They work through the reduction in gastric acid production by blocking the H2 histamine receptors of parietal cells. They are overall weaker acid suppressors than PPIs. Generally, they are well tolerated with few side effects, including GIT symptoms, loss of libido, and headaches. And I suppose taking you back to the dark days of pharmacology, they are inhibitors of the cytochrome P450 pathway and can increase drug concentrations of important drugs such as warfarin, phenytoin, beta blockers, and tricyclic antidepressants. Overall, there's a complete lack of evidence for their use in Lpr. The literature states that they may be used in addition to a PPI in patients with associated gastroesophageal reflux disease, or as an addition in treatment non-responders. Antacids are frequently prescribed in Lpr with little evidence to support their use. They include calcium, magnesium, and aluminium compounds, which are taken to neutralize the pH of gastric contents and refluxate. They're most effective when taken 30 minutes after meals, and also can be taken in anticipation of a reflux-associated event, such as physical exercise, drinking alcohol, or when going to sleep. Allogenate suspensions are added to antacids, such as in Gaviscon Advance, and were initially thought to infer benefit in Lpr. Alginate is a derivative of seaweed, which is postulated to have added benefit through the formation of a so-called raft, which floats on top of the gastric content and theoretically prevents reflux. However, the benefit of alginate is unclear, and in a recent randomized control trial between alginate suspension versus placebo in 80 patients, the alginate suspension showed significant reduction in patient reflux symptoms, as well as on multi-channel pH manometry. However, the study was unable to show superiority over placebo, which again emphasizes the placebo aspect of these medications. The final group of medications is the neuromodulating agents, which includes agents such as tricyclic antidepressants, gabapentin, and pregabalin. At the moment, there's no compelling evidence to support their use, with the literature limited to a few case series. Increasing research investigating their role in even more poorly defined entities such as laryngeal sensory neuropathy, globus pharyngeus, and idiopathic chronic cough also exists. And interestingly, Up to Date, in fact, recommends their addition in the treatment of Lpr where there's no response to first-line agents. And also they say that especially it should be considered if laryngoscopy shows no significant features of Lpr, which if you are in fact actually dealing with Lpr. But nevertheless, their recommendation is for nortriptyline, 10 to 20 milligrams noctave for a trial period of 3 to 6 months. And if there's no treatment response, then it should be weaned over a period of 2 months. Regarding the management of non-responders, this can be challenging and is a scenario we are commonly faced with in our clinics. In patients with recalcitrant Lpr, one should ask yourself a few questions which are kind of common or universal to medicine. Firstly, is the diagnosis correct? And do you require one of the previously mentioned investigations to confirm the diagnosis, such as 24-hour pH monitoring? Or does the patient require pan endoscopy to exclude a more sinister diagnosis like an underlying laryngopharyngeal carcinoma? But if you are confident in your diagnosis, then I suppose the next question you should ask is the treatment regimen reasonable, and is the patient compliant with it? With a non-compliance rate of up to 67% reported in the literature of Lpr. It may be helpful to ask for assistance from our allies, such as the dietitians or the speech therapist, to assist with vocal hygiene and measures to reduce phonotrauma. One may consider referring them to a gastroenterologist or GIT surgeon to exclude an underlying hiatus hernia or other dual pathology exacerbating their Lpr. One may consider increasing the dose of PPI, possibly to a BD dose, or even some literature suggests a change in the type of or brand of PPI. You may also consider the addition of one of the second-line agents, which we discussed previously. And thirdly, I think the other important question which we forget to ask our patients is how important is it for them and how much impact is it having on their quality of life? In an elderly patient whose only joy left in life is a diet rich in kind of spicy foods, cakes, alcohol, and caffeine, is it actually worth it to them to cut out these joys and to improve their minor symptomatology associated with Lpr? This moves us on to what the role of anti-reflux surgery is in Lpr. Anti-reflux surgery is obviously not without associated risk and should definitely not be considered first line, or at least following a trial of medical therapy. It's been shown to be most effective in patients with associated gastroesophageal reflux disease, which has been confirmed on pH monitoring, and in patients who show some response to PPI therapy. The surgical intervention considered specifically is innocent fundoplication, which is now most commonly performed laparoscopically, but can also be performed open, and consists very basically of wrapping the upper gastric fundus of the stomach around the lower esophagus, creating a kind of new neo-lower esophageal sphincter to improve closing function and reduce refluxate. It may be considered in Lpr in two groups of patients, compliant patients with medically recalcitrant Lpr, and also possibly in young, fit, healthy patients who are responsive to medical therapy, but require long-term high-dose PPIs. In a systematic review published in 2019 of 34 studies, including a total of 2,190 patients who underwent Nissen fundoplication for Lpr, 83% of patients exhibited significant improvement of symptoms after surgery, and 67% of patients considered themselves cured. However, like all studies in Lpr, the lack of consensus in diagnosis and again definition was concluded to make it impossible to establish a definitive conclusion on the role of surgical management in Lpr. This is an algorithm which unfortunately does not project very well from the 2019 American Academy Review, which summarizes much of what I've said. In interest of one's eyes and time, I'll not go through it individually. And now moving on to some of the controversies of Lpr. There are many, and I'll just mention a few. The literature is full of studies attempting to establish whether acid reflux plays a role in sinonasal disease, particularly in recalcitrant chronic rhinosinusitis. These have kind of been triggered by small studies like the above 2012 study, which found elevated levels of pepsin and a low pH of nasal lavage specimens taken from patients at the time of revision sinus surgery. And in a 2017 systematic review of 32 studies looking at this association, the following conclusions were drawn. CRS patients may have a higher incidence of reflux and H. pylori infection. CRS may be more prevalent in gastroesophageal reflux disease, and conflicting evidence exists for gastroesophageal reflux disease as a factor in chronic rhinosinusitis treatment failure. And overall, for now, there's no strong evidence, again, at the moment, to support the use of PPIs or other reflux-related treatment in the management of chronic rhinosinusitis. And to my knowledge, similar conclusions are reached in the most recent EPOS 2020 guidelines. A great deal of research has further has been done to look at the association between OME and recurrent acute otitis media in children and adults, where it seems plausible that with the high incidence of reflux, especially in the pediatric population, could it not in fact produce a similar inflammatory process within the middle ear? In a slightly old 2012 systematic review published by the American Academy of 15 Studies, which looked at the association between OME and acute otitis media and gastroesophageal reflux, they reached the conclusion that there is an increased prevalence of gastroesophageal reflux at 48% in OME and 62% in recurrent acute otitis media, which was confirmed with the gold standard pH monitoring when compared to the general population. And secondly, that there's an increase in pepsin levels in middle ear fluid in patients with acute otitis media and OME undergoing grommets. However, the 2 randomized controlled trials included in the review could not find any benefit from anti-reflux therapy in both recurrent acute otitis media and OME. And to my knowledge, there's no newer evidence to dispute this conclusion. And finally, due to the proven association between sustained reflux and pre-malignant Barrett's metaplasia, and specifically adenocarcinoma of this esophagus, over the years, a great deal of research has attempted to establish if there's any similar association in the laryngeal and hypopharyngeal squamous cell carcinoma etiogenesis. And in an excellent 2013 literature review published in Head and Neck, the authors identify that there is definite association between reflux and laryngeal carcinoma. However, there's no evidence to support a causal relationship. This is due to 2 major challenges in the literature. Firstly, the main risk factors for squamous cell carcinoma, specifically smoking and alcohol, which are also known to cause reflux. Therefore, we are unable to ascertain if reflux is an independent reflux or just an association due to the high incidence of gastroesophageal reflux amongst smokers and alcohol users. And secondly, like all Lpr studies, the studies that they rely on predominantly are rely on non-specific clinical diagnostic modalities for Lpr, with few studies using the so-called gold standard 24-hour pH monitoring or even pepsin testing. And therefore, it's hard to confirm if these patients, based on their symptomatology, truly had Lpr, or if they had other causes of laryngeal inflammation like smoking, or if their early symptoms were actually just the first symptoms of early laryngeal cancer. So it's very hard to distinguish the underlying, if Lpr does play a role. Therefore, until we can do kind of a prospective study with something like a 24-hour multi-channel pH monitoring patients without other risk factors for squamous cell carcinoma of the larynx, we'll never be able to truly comment on this relationship, which is obviously a logistically impossible task. Just to note, a recent 2019 systematic review and meta-analysis, which was authored by a group of ENT head and neck surgeons, but published suspiciously in the Journal of Gastroenterology and Hepatology. In their review of 18 case control studies, the authors claim a significantly increased risk of laryngeal malignancy, which remains when controlling for smoking and alcohol. However, when you examine the methodology, you very quickly see the flaws, the most significant being that only 3 of the 18 studies used pH monitoring, and the majority, again, relying on symptomatology and esophagoscopy, which perhaps makes sense now why this was possibly not published in an ENT or Journal of Head and Neck Surgery. So finally, in conclusion, just to reiterate the main points, LPR is common, but we don't know a lot about it. It's challenging to diagnose clinically with no optimal diagnostic modality, creating further difficulty in assessing its role in other pathologies. It's important not to use it as a blanket diagnosis and not to miss red flags of other more sinister alternative or underlying pathologies. And one should carefully reassess and investigate patients not responding to treatment. And finally, the role of reflux in sinonasal disease, otitis media, and laryngeal carcinoma is still to be clearly determined. And I'll end there. Thank you very much. I'll now open to the floor for any comments or questions. Professor Fagan, I'm not sure if you'd like to comment.
Thanks, Brad. I had to do this talk when I was a registrar, so that was about 15 years ago. And I was very confused after the talk, and nothing has changed since then. We are still confused. And I think we were so happy when LPR came along because we have this group of patients that have these vague symptoms. You know, there's a lump in my throat, I clean my throat, my voice is just not 100%. And we were very happy that we could finally do something. So we all diagnosed them with LPR. It was absolutely the fashion of that time. Everybody got treatment. If you didn't respond, you were just a non-responder, you got treatment for longer. If that didn't work, we sent you to GIT, but the treatment remained the same. And I think we have since then, the pendulum has probably changed a little bit, that we now realize it's not the answer to everything. The patients we see in our voice units don't have LPR. They have gastroesophageal reflux disease. They're all overweight. They all have frank reflux. They can tell you that it's severe heartburn. And you see the typical sign, you see the demodulatory or the sulcus vocalist, but they don't have LPR. They have reflux 24 hours. So I'm not sure how often we do see LPR or we misdiagnose it. I think the sore throat is one of those things, or the lump in the throat. It's still something we don't always understand. So we want to diagnose it, and LPR is an easy diagnosis for us to make. But I think it's very important. If they don't respond to treatment, then it's most likely not LPR. And then you've got to think, can you help it? Or then you must maybe be honest and say, listen, everything looks normal. We know you don't have cancer. You've scoped possibly 2 times, you know, and then discharge them and not hang on to them forever with the diagnosis they probably don't have.
Thank you, yeah, Matt, a really good presentation. And I think you had a red flag. I've seen 2 or 3 patients in my career who've been seen by colleagues, you know, with some voice change or sore throat, and they, you know, and they're given PPRs and sent off, and then they come back and they've got a cancer, which is missed. So I think that's so important to exclude. But certainly, I think that is a great presentation. But it still leaves us hanging.
And I think we must accept that and rather say we still don't know than keep on diagnosing with something that we want to make a diagnosis because that's how we are. But it's maybe still not the diagnosis yet for these patients.
Another point just is that the PPIs are expensive. And I think you must always just caution your patients, because you mentioned the issue about weighing up the symptoms against treatment. But I think you should also weigh up the cost against treatment, because especially now in tight financial times, some patients really would struggle to meet the cost of PPI medications.
Would you still, so I've got this figure that if somebody is a smoker and they have continuous symptoms, that you would, even if though the scope is normal, you might possibly take them to theatre for a scope, just to exclude if they've got a risk factor. Would that be
I think it depends. I think it depends on the symptoms. If it's really voice change, you see vocal cords is fine. If any pain or discomfort, or diaphragm, then I think we should be there. Any comments from Kenneth Ivy or from Victor Mashamba, or anyone from Epidemiology?
Good morning. This is Kenneth. There's nothing much to add except that it's still as confusing as it was when I reviewed it not too long ago. But what I have realized is in some of the recalcitrant cases, most patients usually have an underlying H. pylori infection, which when you treat improves at least the symptoms in the patients. But I looked at the literature and there's nothing to support that. But from my empiric practice, I think once you are having issues with patient response to treatment, look for H. pylori and treat it if it's present. And sometimes the responses are improved. Thank you.
So thank you very much, Professor Fagan, Dr. Baidu, and Dr. Mayer. Seems I haven't achieved my goal, and everyone seems still relatively, or if not more, confused after my talk about LPR. I know I definitely am still quite confused myself. Are there any other comments or questions? I don't see any on the chat function. Anything any of our exam candidates would like to ask? I don't know if by any chance Professor Libber is there to comment on the role of LPR in rhinosinusitis.
No, she isn't at the moment.
Okay.
Well, thank you very much. That was a great presentation.
Thank you very much, Prof. And thanks to everyone for attending this morning, and I'll conclude here.